like to acknowledge the traditional owners and custodians of this land and pay our respects to elders past and present. So the Women's Health New South Wales office, it's on Gadigal land, but our work takes place on unceded Aboriginal lands across New South Wales. I would like to acknowledge, in light of the purpose of today's meeting, those who may have lived experience of abuse and violence, and recognise that some of the participants within the room may have their own experiences as well. So my name is Courtney Artridge, and alongside my colleague Jackie McMillan, we work at Women's Health New South Wales. We are the peak body for 21 non-government, community-based women's health centres and special purpose services that operate in New South Wales. Each women's health centre marked on the map supports the women in their local community using a multidisciplinary response. Roughly 60% of our workforce are counsellors. However, we do have doctors, nurses, and case managers, just to name a few. Today, I'm going to share key insights from the Pathways project. This project came about when we identified a need to strengthen professional understanding and local capacity to respond to sexual assault-related non-fatal strangulation and acquired brain injury. To make sure the information is relevant to you in primary care, we're joined by our guest speaker, Dr. May Su. So as the chair of the Royal Australian College of GP Special Interest Group, Abuse and Violence in Families, an academic GP and a PhD candidate on the use of interpersonal violence, as well as a GP supervisor and a practicing GP, Dr. May Su has been a valuable collaborator for us at Women's Health New South Wales, often helping us contextualise resources for GPs during the Pathways project. So today, Dr. May Su will be sharing her experiences to demonstrate what our training insights look like for her in her clinical practice. So the first thing we did when delivering the Pathways project was we mapped the available evidence on strangulation and brain injury to ensure what we did was evidence-based. So spoiler alert, there were gaps in Australian data relating to women's experiences of strangulation and brain injury. You can check out what we did find in the evidence brief pictured on the screen here, and which is also available on our website. While this started solely as a sexual violence project, when mapping the evidence, we discovered we couldn't address sexual assault-related strangulation without also addressing strangulation in the context of domestic and family violence and strangulation enacted with consent in a sexual context, commonly called sexual choking. In today's session, our primary focus will be on strangulation in the context of violence. While the health consequences of strangulation and sexual choking, they can overlap, we found that we needed to approach these issues differently, something you'll see drawn out in the project evidence brief and the information for women on our project website, itleftnomarks.com.au. We called the website It Left No Marks because almost half of women who have experienced strangulation will have no visible signs that it occurred. I'm using the term women to be consistent with our remit at Women's Health New South Wales, and because the research indicates in the context of violence, it is most often women who are the ones being strangled. So to help set the scene, we will start with a case study from one of our regional women's health centres that we work with. So Grace is 47, and in 2026, she moved to regional New South Wales to escape a violent relationship. She arrived in her new town, excited about getting back into the workforce and resuming her career as a nurse after her experiences of violence and declining mental health caused her to stop working. As a nurse, Grace recognised the importance of medical follow-up after experiences of violence. She had sought help previously while she was living in the violent relationship, but at the time felt disclosing the full extent of her partner's violence would jeopardise her safety. So, after years of enduring violence, Grace was able to escape her ex-partner and turned up at the Women's Health Centre in her new town, seeking mental health support. As part of a routine risk assessment conducted at the centre, the counsellor used plain, simple language to screen Grace for strangulation. Grace revealed a long history of intimate partner violence, including repeated strangulation events during sexual assaults. This disclosure prompted the counsellor to refer Grace to a GP. Together, they completed a medical referral letter to help Grace communicate the signs and symptoms she was experiencing and the impacts she felt the strangulation had had on her day-to-day functioning. In the referral letter, the counsellor also explained which services the Women's Health Centre would continue to provide to Grace. She used the referral to let the GP know the centre was going to take care of Grace's mental and psychosocial needs. This enabled the GP to do what they do best, manage her neck and potential head injury. On the screen, you can see an example of what a portion of Grace's referral letter may have looked like. The medical referral template has been particularly useful for women who find the process of explaining what's going on stressful or challenging due to their experience of domestic, family, and sexual violence, the trauma of retelling their story, and all the complications from a potential brain injury. So Grace followed up with her new GP, equipped with information in the medical referral letter and additional information provided by Grace. Her GP completed a physical examination and ordered medical imaging to investigate a potential brain injury, neck injuries from the strangulation, and injuries to her reproductive system caused by the sexual assaults. The medical investigations found evidence that Grace had previously had a stroke that went unrecognised. A specialist directly attributed this to her experiences of strangulation. She had damage to her esophagus from the strangulation, which required speech therapy. Grace's eyesight was also deteriorating, and she was given a prognosis of eventual vision loss, impacting her ability to work and requiring long-term medical care. Grace continues to work with the Women's Health Centre and her medical team as she strives to heal from her experiences of violence, manage her deteriorating physical health, work towards financial stability, and achieve desired legal outcomes. So Grace's story demonstrates the way a woman's experience of strangulation impacts their physical, emotional, mental, and psychosocial health. Grace's experiences also highlight safety risks for women living in violent relationships. Dr. May Su, what things would you talk about if someone disclosed a recent strangulation, so say under 4 weeks, compared to a historical strangulation, so say over 3 years?
Look, thanks very much for everything that you've shared so far, Courtney, and I really want to empathise and resonate with anyone else who may be have experienced things which Grace's story might trigger or bring up. And I guess in terms of this particular question, I would say as any first responder, the preeminent concern is going to be assessing risk. So in the context of assessing immediate physical harm, I would want to know the nature of the injury associated with the strangulation, the recency, the timing. You have mentioned potentially less than 4 weeks, which I think is a bit of the window of what we're looking at in terms of recency. And if there are any associated injuries. So you'd be asking specifically about symptomatology or sequelae. What you're really trying to assess is, had there been, as you said, any physical injuries to the brain or neck, including hypoxic injury, injury to the soft tissue or bones, the airways, and the great arteries and veins. And if there's been prolonged hypoxia, you might want to ask about duration, periods of unconsciousness, confusion, memory loss, seizure, or incontinence. Those last few criteria make it much more likely that you would be concerned about a longer duration of injury and potential hypoxic injury as well. And so then you might also be exploring the likelihood of hypoxic injury to other end organs as well, like you've already mentioned in Grace's story as well. They're going to need support for the psychological impacts, which I know is already being addressed in this story with the Women's Health Centre, which is fantastic, but we will talk about that a little bit later as well, about how we address that within a primary care context as well. And there may have been alcohol or other drugs involved, which might need to also be assessed as well. If there's any obvious airway compromise, respiratory distress, or any evolving neurological symptoms, this warrants an urgent assessment in emergency. So at that point of time, that they really need to be assessed on an urgent situation. They might require imaging, for example, a CT or MRI brain, neck, or a CT angiography. So that's looking for carotid dissection, so the big vessels. They might require what we call a nasendoscopy, where they put a tube and actually physically have a look at what's happening, and that's to look at kind of the soft tissues like the larynx and seeing if there's any injury to that area, which is like what was described in Grace's circumstance as well. So if the injury was within 36 hours, you might need to ongoingly monitor them, because you may actually find that due to the nature of the injury, including potential edema, there might be an evolving presentation as well. In the context of assessing domestic violence risk, I'd want to know how recently the exposure was, as I mentioned, the relationship to that person and whether they're still in contact or likely to continue to be in contact, and what the context of the described strangulation was. I think sometimes we do see the circumstance where people may not actually be aware of the impact of the strangulation in terms of the risk to themselves and also its role within potentially a DV situation. And sometimes that's a retrospective awareness that they come to. Are there children involved as well? So your toolkit is a Western Australia-based resource. I know this is New South Wales-based, but we do sometimes use resources elsewhere. And that's extended to include national resources aimed to help with safety planning, where the person may potentially still be in contact and at risk. So it might be worthwhile considering in terms of your safety planning as well. And it's possible that your documentation of the events might have medico-legal impact. So it's really important to seek advice on how to appropriately respond and record if you suspect that there's been strangulation. In this situation, Grace has come to see you in the context of historical experience of strangulation. Like, that's probably where you're more likely to come across a presentation like this. And it's quite likely it's taken quite some time for Grace to be able to disclose her experiences to you. General practitioners are often the first person disclosed to, and there can be a lot of shame and stigma associated with the experiences of being a victim survivor, particularly when it might be in circumstances like this, where there might have been other activities, including sexual, involved. Survivors might take a lot of time to understand what's happened to them, let alone be able to even describe that and share that with another person. So the description of their experience might not actually be very coherent, and you do need to be really conscious about being empathic about that process for them. It's very common for that to occur, and it reflects the nature and process of any traumatic event. Sexual strangulation, as Courtney has said, may sometimes appear to be consensual at the time, and the person might only realise after the event that that wasn't actually a safe experience for them. So a really crucial aspect of disclosure is that to do so can be really incredibly vulnerable, and it indicates trust that the listener will listen and respond appropriately. So the Royal Australian College of General Practice endorses the WHO, like World Health Organization, LIVES approach, which is listen, inquire about needs, validate, enhance safety supports. And it's just a really lovely framework that any first responder could use. The Safer Family Centres also developed the CARE model, which is about choice and control, action and advocacy, recognition and understanding, and emotional connection. And that framework provides a guideline for what women survivors want from the health practitioner following a disclosure. So it's about balancing the empathy with the pragmatic while ensuring that choice and control is held by the survivor throughout the process. And if there's long-standing sequelae, such as acquired brain injury, they might need some assistance to access their usual health needs or external supports if they're going to be long-standing deficits. So they might need to be supported in any transition to an additional person involved in their care, which we'll talk to later. And there might be regional legislative requirements for mandatory reporting. So you might want to refer to some local resources such as Health Pathways, or speak to 1800-RESPECT, which is a national line that you can speak to. Anusha Victoire, Victoria Du Bois and Joanna Lynch have written a really excellent article on the management of non-fatal strangulation in general practice. So that was published in 2022 in the Australian Journal of General Practice. And as Courtney has shared, the It Left No Marks resources are really fabulous as well.
Thank you, May Su. And certainly some of those points we're going to unpack a little bit more Okay, so domestic, family, and sexual violence is the most common context women reported experiencing strangulation at the women's health centres we worked with. Strangulation also occurs in the context of sexual assault and in consensual sexual choking. The most recent Australian study on sexual assault related non fatal strangulation was published in 2026, and it told us that 7.4% of sexual assaults involved strangulation. Strangulation occurred most often at the hands of their intimate partner rather than acquaintances, friends, or strangers. Data from 2021 found 27% of women who had experienced coercive control also reported that their partner had strangled, choked, or grabbed them by the throat. Information on the prevalence of sexual choking in Australia only emerged in the last couple of years. In 2024, a nationally representative study found more than half, so 56.9%, of Australians aged between 18 and 35 reported having ever been choked. Trans and gender diverse participants were the most likely to have ever been choked at 78%, followed by women at 60.5% and men at 42.8%. While in this webinar, we're focusing on strangulation in the context of violence, prevalence rates of sexual choking and the risk of injury make it an important consideration during sexual health checkups. It's worth noting that the same victim and survivor may be negotiating strangulation in one part of their home and sexual choking in another, but view their role in each situation very differently. So we need to consider carefully how we support victim survivors to disclose and make sense of the co-occurrence of strangulation and sexual choking. So in the next few slides, we're going to talk more about a woman's clinical presentation and what the research says about the long-term health implications of strangulation and sexual choking. The key resources that support healthcare providers when it comes to identifying strangulation injuries, the medical examination and management of strangulation include the New South Wales Health AIC clinical guidelines for managing non-fatal strangulation in the emergency department. And this article, the 2022 article from the Australian Journal of General Practice about the management of non-fatal strangulation in general practice. Health Pathways is also a source of vital information for managing strangulation. We were fortunate enough to be able to have some input into the health pathways for domestic abuse and sexual violence last year. You'll find some of our project resources on there as well. You may also find clinical guidelines relating to brain injury also relevant, like this 2026 article from the Australian Journal of General Practice about managing neuropsychological symptoms in general practice. So in the article, Management of Non-Fatal Strangulation in General Practice, Dr. Anusha Victoire and colleagues provide a table on the mechanism of injury and clinical features of strangulation, like the one that's on the screen here. The article's key message is the sudden interruption of both arterial supply and venous return, and how that can result in hypoxic or vascular injury with no external sign of injury. This is supported by an Australian study that found nearly half, so 49.4%, of all non-fatal strangulation-related sexual assault cases revealed no external physical signs of strangulation, with almost a quarter of strangulation cases showing neither signs nor symptoms. Another American study that reviewed autopsies of those whose deaths were a result of strangulation found that despite it being the cause of death, some victims had no external signs of strangulation. This is a reminder that despite not having obvious physical injuries, those who experience strangulation may have a serious or life-threatening injury. Strangulation that occurs in the context of violence and in consensual sexual choking can lead to a range of injuries that are dependent upon the area where pressure is applied to the neck, the degree and duration of pressure, and any associated shearing force or extension of the neck. For example, Pressure to the back of the neck can cause injury to the spine and/or spinal cord, which may result in permanent spinal injury. This tends to occur when the victim survivor has been lifted off the ground or shaken during the incident, which is something you can listen out for when you ask your patient what happened during the strangulation event. This slide identifies both the visible and the hidden signs of strangulation. The hidden nature of signs and symptoms make applying a trauma-informed lens vital. This includes taking disclosure seriously and using professional curiosity and follow-up questions appropriately to fully understand her experience and respond to her needs. So in the box, we can see a list of hidden signs of strangulation. Hidden signs can be difficult to identify because the screener is unfamiliar with the patient. In your clinic, what this might look like is if it's your first time seeing a patient, you won't know what her baseline behavior is or what her normal voice sounds like. You will need to ask questions to know if there has been any changes. If she has limb weakness or blurred vision, again, you won't know this unless she discloses it, and she may not tell you if she has minimized the seriousness of the event or if her circumstances, such as sexual violence or domestic and family violence, impact her decision to disclose. There may also be times her symptoms may be attributed to something else. For example, if she's confused or clumsy, you may think that she's intoxicated. Memory loss can also be tricky. Not all women will recognize that they have memory loss. This can make taking a history difficult. So we need to explore responses like, I don't remember and I don't think so. These points emphasize the importance of using a trauma-informed approach to ensure we don't miss anything in medical appointments and women get the care they need to heal. We'll talk more about a trauma-informed approach a little bit later. So when it comes to how much time a woman has before serious injury or death, we have a single US study to guide us. The study was completed in the 1940s before research ethics was such a strong consideration. A few things that are important to note here. All study participants were male and they were aged between 18 and 31 years, and not all of them were healthy. And the pressure applied to the neck was done by a cuff that allowed for it to be measured. These all reduce the data's credibility for applying it to women experiencing strangulation. Despite these problems, what we can take from the study is that there is a consistent sequence of symptoms when pressure is applied to the neck, interrupting blood flow to the brain. For example, a short time after pressure was applied to the neck, participants lost consciousness, followed by convulsions, then involuntary urination, and for some participants, a loss of bowel control. Importantly, after 30 seconds of continued pressure being applied to the neck, participants experienced bradycardia. At this time, researchers stopped applying pressure to the neck. In some situations, the researchers used atropine to get the participants' heart rate back up. The most important thing to take from this timeline is the order of events. So loss of consciousness, loss of bladder control, convulsions, and so on. The time at which each condition occurred isn't as helpful because of differences in individual physiology and in the incidences of strangulation. No one is measuring the precise amount of pressure. It is the order of events that are going to help you identify when more serious injuries are likely. For example, if she reports losing bladder or bowel control, we know she was strangled past the point of losing consciousness and is at a greater risk of serious injury. So this diagram from a UK study reviewed patient records from a sexual assault service, and it demonstrates that although not all victim survivors who experienced loss of consciousness lost bladder or bowel control, all those who did lose bladder or bowel control lost consciousness. Keep in mind, women may not always remember or connect their experience of strangulation with losing bladder or bowel control. For example, she may say that she was scared, so scared that she peed herself. If you're unsure, you might ask, did you change your clothes after the incident? There is growing evidence for the need for a high index of suspicion for brain injury in people who have experienced strangulation and hits to the head as a result of domestic abuse and sexual violence, and or engaged in consensual sexual choking. Recent evidence has found women who experience strangulation and or engage in sexual choking frequently experience changes to the structure and function of their brain, and that multiple mild brain injuries are correlated with cognitive deficits later in life. For example, a 2021 study found women who have been choked more than 5 times in their lifetime are more likely to report symptoms related to depression, anxiety, sadness, and loneliness compared to those who had never experienced sexual choking. More recently, a Melbourne study found the combination of traumatic brain injury and strangulation resulted in worse social deficits and white matter damage, impacting memory, balance, and mobility. In the same year, another Australian study examined whether those who had experienced intimate partner violence and brain injury had chronic impairment. They found evidence of impairment in memory and new learning, with worsening cognitive outcomes among women who had experienced both intimate partner violence and brain injury, compared to women who had only experienced intimate partner violence and a healthy cohort. This study provides insights into how we can differentiate between what symptoms are related to experiencing trauma and what symptoms are caused by brain injury. What do these studies mean for those working in general practice? It means we need to start screening for intimate partner violence and brain injury. And when intimate partner violence and mechanisms of brain injury are disclosed, neuropsychological assessment, targeted health promotion, and long-term medical follow-up should be provided. One of the barriers practitioners at the women's health centres we worked with faced was making a multidisciplinary response that supported the clinical management of women's acquired brain injuries. A major contributing factor is the complex presentation of brain injuries. As the Women's Health Alliance pointed out in the position paper you can see on the screen, acquired brain injuries are common but underdiagnosed and underreported in women, especially in those affected by domestic and family violence. This is connected to the way that women's brain injury symptoms are often dismissed or are wrongly attributed to psychological issues or alcohol and other drug use, again, particularly in women with experiences of domestic, family, and sexual violence. As the main coordinating point for women's health issues, GPs play a vital role in supporting women to identify and manage their brain injury. So in June 2025, we worked with Central and Eastern Sydney, Hunter New England, and Nepean Blue Mountain, PHNs, to deliver training to GPs in their local area. So Dr. Jamie Berry, the founder of Advanced Neuropsychological Treatment Services, so ANTS, and senior clinical neuropsychologist, joined as a guest speaker and spoke about what signs and symptoms should prompt GPs to conduct a neurological assessment. So let's listen to what he had to say now.
There are multiple mechanisms that could lead to acquired brain injury in this situation. You've mentioned traumatic brain injury or stroke or hypoxic brain injury. Now, each of those might manifest slightly differently in terms of the neurological and neuropsychological sequelae. But in general, one would be looking for general neurological signs, things like motor and sensory signs, weakness, motor incoordination, paresthesia, so tingling or numbness, visual disturbances might be a sign. It's also important to look for changes in things like speech and language, slurred speech, or doesn't make sense. And this would be particularly easy to recognise if the practitioner has an ongoing relationship with the person, because clearly they can tell when something is a change. Obviously, presence of seizures, particularly first-time seizures following an event, might be an indicator. In terms of the more cognitive or neuropsychological signs, a person might appear more forgetful in their everyday functioning. They might be slower in their thinking and a bit foggy in their thinking. That's been reported in the literature. They might struggle to keep track of a conversation, so they might lose their place in conversation. So these are things that might be signs that a practitioner could pick up during a consultation. In terms of the symptoms that are reported, and there is a literature, there was a systematic review published in 2022 that focused mostly on symptoms, and sadly it had to focus mostly on symptoms because the reviewers couldn't identify any single study that had done prospective cognitive testing. But the symptoms that have been reported in the literature include things like memory problems, difficulties concentrating, difficulties just getting daily tasks done and keeping track of things. It could be keeping track of bills or activities of daily living. The person might also describe changes in their personality or their emotionality. They may become more tearful than they were, which could be an indicator of emotional lability. Of course, that could also be an indicator of a psychological response. And it's very hard to tease apart the organic from the psychological factors, but it is possible that heightened emotionality in the form of emotional lability could be an organic indicator of brain damage. The person might report having a shorter fuse, and other symptoms that are often reported include fatigue. Fatigue obviously is not always physical. Mental fatigue is actually a common sequelae of acquired brain injury. And so a person's likely to become mentally fatigued when they're investing mental or cognitive effort into a task. That could be having a conversation or watching a movie. So if a person's reporting that they're feeling more tired, even in the absence of physical exertion, that could be an indicator. There are other neurological signs, of course, such as headache and dizziness and things like that.
I think this is a good time to refer to you, Dr. Wei-May Su. What do you do in your practice if you suspect or a patient was diagnosed with an acquired brain injury?
Yeah, thanks, Courtney. Look, I would actually comment though that Dr. Jamie Barry has actually provided a really beautiful, succinct description of some of the things which make you consider an acquired brain injury. So I may focus in how I respond to this to maybe thinking about the practical implications of how we might manage this within a general practice setting then as well. And I really do want to emphasise that the real critical thing about an acquired brain injury, as opposed to people having executive functional difficulties for any other reason, is often about the fact that their functional impairment is demonstrably different from their function pre and post injury. And some of that, you are correct, might be psychological and the trauma associated, but even if there are multifactorial facets to their presentation, we can be trying to unpack that at the same time as we're managing that at the same time. So, you know, you don't have to have your diagnosis before you start actioning it, because sometimes it's only as you start doing things about it that you can get a better, clearer picture about what's actually occurring. So it is about just slowly picking apart all the bits and working out which areas are high priority or urgent issues that you kind of have to sort out now. Essentially, I would want to work out what is this person's actual capacity, how much support will they need to be able to work through these issues. They might already have supports in place, but we want to enhance and build upon them. So I would want to have specific examples of how they manage when they're challenged, and this might be really highly variable depending on the context. The comparison is going to again be with their pre-existing function, and has their capacity to work changed? If so, how? And the reason that's really relevant is if they've had the capacity at some point There's a concept called cognitive restructuring. So sometimes what you're doing in the management of them is working out some processes so you can regain some of what they previously were actually able to have the capacity for. As opposed to if this was something they've never had the capacity for, then you might manage that a little bit differently. You know, I do think I might also want to kind of work out what are the specific examples of which bits they're having difficulty with. So again, this was actually addressed with Dr. Jamie Berry, where he talked about sense disabilities and emotional regulation disabilities and executive functioning and fluid reasoning difficulties. But in your management of it, it's quite useful sometimes to pull apart which are the actual bits that they're having difficulty with, because then you can actually address which bits you're actually working on. And so then you can set up your structures and supports around it. So, you know, for example, if they are having more effort into thinking or reading, you know, is it a difficulty with an impairment of sense or memory? Is it a difficulty more problem solving? Or emotional regulation? Are they okay with their usual activities, but they might struggle when there's anything new or when there's too many things happening at once? Or is it in specific settings which might make you think more of a PTSD or complex PTSD presentation as opposed to it being present all the time? So the reason that's relevant is, for example, if you have particular supports that person needs to function, you could be able to rationalise that you have it present at particular times when that person's more in need. And so, you know, if the impairment's like about sense, so again, Dr. Jamie Berry talked about sense issues like vision and hearing. So you might be thinking about things like accessibility aids. If it's memory, they might need a process to ensure they're recording events and information. If they need a support person as a fixed schedule, such as or a process of managing appointments, we call them this social scaffolding. So where there are social structures put in place to compensate for the known impairment. And so that can be a really helpful strategy for particularly in settings where the impairment is prevalent throughout most of the time as well. For some patients, as I mentioned, you can potentially redevelop skills in problem solving and fluid reasoning through cognitive restructuring. So you're essentially trying to relearn through new neural pathways. And the same is true for emotional regulation, which I think is probably a concept that, you know, many in the room are probably a little bit more familiar with, but you can do a similar process with cognitive restructuring as well, and with the potential additional input of pharmacotherapy as you need to as well. So neuropsychiatric testing might help you assist with clarifying the functional impairment, because I'm not expecting everyone in the room is going to feel like they can tease all of that apart, but just be mindful of thinking if you can narrow it down, you can be a bit more specific about this, what the structures and processes of support are going to be. And this may be available privately or through referral through a brain injury unit, or an OT might provide some pragmatic suggestions in how to manage their impairments as well. So they could be eligible for NDIS as well. And don't make the assumption that they've already been assessed for a brain injury, even if they've had their medical needs attended to, because in an acute setting, sometimes these things kind of fall through the cracks as well.
Thank you, Dr. May Su. I really liked that emphasis on breaking it down to what the issue is so we can focus on helping improve those parts of their lives that they're really struggling with. I think that's such a valuable insight there. So in the rest of the training, I will share 3 key insights from the Pathways project. They can all be used in general practice settings to improve health outcomes for women with experiences of strangulation, sexual choking, and brain injury. These insights are choosing the right words when screening, making a multidisciplinary response, and delivering appropriate health promotion. To help unpack these insights, I'm going to share another case study from a women's health centre in regional northern New South Wales. So Opal is a 49-year-old single mother who had been unable to work for several years due to poor mental health. Opal first engaged with Women's Health Northern Rivers as part of the Worth program. This program was designed to support women in the local area after devastating floods in 2022. Through the program, Opal received ongoing counselling. During one of Opal's counselling sessions, she disclosed that she'd experienced domestic and family violence when living with her ex-husband. Opal said she escaped the violent relationship 15 years ago after her ex-husband burnt the family home down. After this disclosure and in the same consultation, the counsellor used plain, simple language to screen Opal for strangulation. Opal revealed that she had been strangled multiple times by her ex-husband. This led the counsellor to complete a strangulation assessment that included looking at whether Opal had any medical red flags that would indicate a potential brain injury or other long-term health conditions caused by the strangulations. As part of the assessment, the counsellor used a conversational approach to find out more about the strangulation events and determine their severity and Opal's risk of brain injury. Opal stated she was strangled multiple times, and her description of what occurred sounded like she lost consciousness on at least one occasion. Using open-ended questions, the counsellor helped Opal to identify any new or evolving neurological symptoms that had occurred since the event. Together, they found Opal had experienced multiple cognitive, sensory, and physical symptoms, and they included post-traumatic stress disorder, anxiety and panic symptoms, memory problems, cognitive processing issues, fatigue, visual difficulties, specifically trouble locating objects, chronic pain, balance and mobility issues, and a tight jaw. These symptoms have had a significant impact on Opal's quality of life, and in the previous year contributed to her having a mental health crisis at work. At the time this assessment was completed, Opal was unemployed and relying on government benefits for her daily living expenses. On the screen, you can see images of the Women's Health New South Wales strangulation assessment tool. On the second image, you can see the practitioner instructions in the left column and the results of the assessment in the right column. This assessment tool, which is designed for community workers rather than healthcare workers, is available on our website. So what happened next? The counsellor delivered health promotion designed to encourage Opal to seek further help. She supported Opal to make the connection between her experiences of strangulation and the current health impacts she was struggling with, even though these experiences occurred over 15 years ago. Opal was supported to discuss her experiences and symptoms with her GP, whom she trusted. They filled out a medical referral letter together to help Opal communicate what's going on for her. Through this community service, Opal was able to access case management and social worker support for further psychosocial assessment. She also accessed neurophysiology and physiotherapy for further assessment and management, and occupational therapy to support an application for the disability support pension. These services were all free and provided at the Women's Health Centre. The centre also provided fuel vouchers to travel when she needed medical scans and gap fee coverage to pay for those scans. Opal found this response validating and felt supported for the first time. However, beyond the Women's Health Centre, the system wasn't working for Opal. Her biggest concern was her deteriorating health and the possibility of permanent unemployment leading to homelessness. Opal wasn't eligible for financial assistance Opal wasn't eligible for financial assistance under the Victim Support Scheme in New South Wales because the violence happened more than 10 years ago. Her eligibility for the disability support pension was complicated because she didn't yet have a medical diagnosis for a brain injury. A few months after this case study was written, the service informed us Opal's application for the disability support was finally successful. A major contributing factor for this success was the collaboration between the Women's Health Centre and another local organisation that helped Opal produce a strong application based on her PTS diagnosis rather than her potential brain injury. The financial support gained from her initial application will support Opal as she continues to recover from her abuse, and in the future, it can be expanded to allow her to access the services needed to address the potential brain injury. The case study shows the first time Opal received support directly related to her experiences of strangulation was 15 years after the incidences occurred. The time between experiencing strangulation and being screened reflects the barriers women face in disclosing strangulation and highlights the need to improve the way we screen. It is also estimated that a full-time GP sees around 5 women per week who have experienced intimate partner violence in the last 12 months, representing an opportunity for early intervention and ongoing support. Strangulation is a commonly misunderstood term, shrouded in alternative labels and misconceptions. The differences in terminology used by the media, the general public, sector workers, the law, and academics all impact reporting rates, limit the accuracy of screening tools, and impede effective service responses to women. Strangulation sounds very serious. It's the term used in the New South Wales Crimes Act. This can make victim survivors choose alternative language to minimise the seriousness of strangulation. An Australian study found some women do not disclose strangulation because they do not relate their experience with screening questions. Dr. Anusha Victoire, who co-wrote the article we showed earlier on managing non-fatal strangulation as a GP, concurs that many of her patients didn't associate their experiences with the word strangulation because to them, strangulation meant being killed. A UK study asked the same group of victim survivors 2 questions. When the women were asked if they'd been strangled, 45% said yes. When the women were asked if they'd been held in a way that meant they could not breathe, 75% said yes. To help address barriers related to confusion about terminology and potential minimisation by victims and survivors, we recommend using benign and general questions about pressure being applied to the neck or being held so you cannot breathe. This approach worked. One women's health centre we visited told us they saw very little strangulation, despite their core business being domestic and family violence. However, after our training, they changed the way they asked the question on the New South Wales DV risk assessment tool, the DV SAT. They now ask, was pressure applied to your neck or were you held in a way that made it hard to breathe, even during sex? When women usually start to shake their head, until the questioner gets to even during sex, and then they nod yes. 4 months on, one worker we trained at that centre told us that 90% of the clients she sees have experienced strangulation. All of the guidelines we co-developed with the women's health centres provided guidance to practitioners on screening for strangulation that is relevant to the way that that centre operates and the various communities that they serve. So, for example, one women's health centre chose to implement routine screening for strangulation, while other centres wanted staff to screen if there were indicators of or disclosures of domestic, family and sexual violence. Importantly, data from those centres who did implement routine screening showed disclosures of strangulation occurred in doctors' appointments where the women's presenting issue was cervical screening and sexually transmitted infections. All women's health centres supported staff to modify the suggested screening question based upon the client in front of them. Some examples of these modifications included changing the word sex to intimate times to work better with some groups of culturally and linguistically diverse women who responded poorly to direct discussions of sex. We also supported women attending our centre making disclosures with a poster that you can see on the screen here. Our members used it in their waiting rooms and treatment rooms as a conversation starter. It lets the woman know that strangulation is safe to discuss. In the PHN webinar we mentioned earlier, Dr. Ali Friedman, sexual health physician and senior clinical advisor to Ministry of Health, reminds GPs of the importance of identifying both recent and historical strangulation events. So let's listen to what she had to say here.
So we began to draw the link between sexual assault and strangulation, and as services started to ask all their sexual assault patients, their recent sexual assault patients, about whether they'd been strangled in the most recent assault. So sexual assault services tend to see someone within 7 days of an assault. We started to ask people about, did you experience strangulation as part of that assault? We discovered that it was quite a common thing. And then a few other studies which have looked at prevalence of sexual assault, prevalence of strangulation, have managed to kind of find more correlation, more kind of subtle differences in the sexual assault population. So within that sexual assault population, strangulation is common. Strangulation is more common in women who are sexually assaulted in the context of a domestic violence relationship. So it's began to become very clear to us that strangulation wasn't just a part of a sexual assault, but it was probably part of that pattern of controlling behavior and physically controlling behavior that happened in domestic violence. And we're beginning to understand more and more about how common strangulation is as a weapon of fear and control within domestic violence. So again, if we see people and they've had a recent assault as part of domestic violence, or they disclose domestic violence, we always ask about recent strangulation. We're concerned about acute strangulation injuries. But I guess the area that we're really beginning to pick away at and beginning to understand is that for many women, they've had ongoing violence and they've had ongoing subclinical strangulations and probably head injuries as well as part of either ongoing domestic and family violence or repeated different traumatic experiences, usually within the context of a partner relationship. And so we're really beginning to try and understand a bit more now about what the implications for women who've survived violent relationships are, what the kind of implications of repeated anoxia, repeated strangulation, repeated head injury are. So we kind of are beginning, we've kind of got some good models of care now looking at those acute strangulations happening often in the context of sexual assault or physical assault. We're thinking about the people who are living long term with the long term effects of repeated strangulations.
So, screening for sexual violence, domestic and family violence, and strangulation is more than just getting the words right. For many, their experiences are a deeply personal and sensitive topic. As healthcare providers, you have the challenge of having a limited amount of time to create a safe space for patients to empower them to make disclosures. Some tips for doing this are remaining non-judgmental by taking the time to listen to the patient and believing them. It includes avoiding language and expressions that might shame, criticize, or blame women for the violence perpetrated against them or for not leaving the violent relationship. Remember, it might be safer for her to stay. The next point is prioritize patient-centered care. For example, give her choices and involve her in shared decision-making about her own care. Provide adequate time to complete the consultation. The health implications of experiences of violence are complex and overlapping and often require a longer consultation. Dr. Anusha Victoire provided an example of how she manages these complex appointments at the brain injury event we ran last year. We'll watch what she has to say now.
I can tell you as a GP who looked after many women in this sort of situation, they're the really hard consults. You know, they come in with a 15-minute appointment that either they won't turn up for or it takes 50 minutes and throws your whole day out of whack. So I learned strategies to try to accommodate that. So some of my triculars would schedule a regular appointment at the same time on the same day every month or every fortnight, whatever they needed, depending on if they were in crisis or not. We'd schedule it at the end of the session. So if they didn't turn up, great, I've got extra time to check my results and have lunch. If they did turn up and it went over, fine, it's not impacting other patients. And we'd kind of compromise in that way.
Another way to provide a safe space is to demonstrate to the patient that you're prepared to talk about these issues. On the previous slide, we spoke about putting a poster up in waiting rooms. Proactively screening for strangulation and domestic and family violence also shows that you're ready to discuss these issues. Campbelltown Emergency Department shared a few examples of this approach working. So when a male patient was observed to be verbally aggressive to his wife, a doctor found a private moment to ask the wife if her husband was ever violent towards her, even though she wasn't the patient. When she said yes, they connected her with a caseworker while he was receiving treatment. In a second example, a doctor on the ED team did a screen for domestic and family violence. The patient was asked if she was afraid of her partner, and she said no. But a short time later, the patient approached a nurse and said, when the doctor asked her, she was so surprised by the question, she instantly said no. But the answer is yes, she is afraid of her partner. The ED staff were able to discreetly connect her to the right services. Finally, offer an interpreter if the patient's first language is not English, unless you can speak their language, of course. So, Dr. May Su, what techniques and strategies do you use to help build rapport with clients and to create a safe space that facilitates disclosures of domestic family violence and or strangulation?
Yeah, thanks, Courtney. Look, I think it's really helpful to have signposting within the practice that you're open to talking about domestic, family and sexual violence or sexual health, sexual practices, because these are probably going to be the most likely context that you're going to see strangulation. So just to point to that, I guess the context in which you work may depend on whether you're screening or whether you're case finding. And I think that talks to something you were talking to before, Courtney, about why there might be the variance, about why there are the different recommendations on that. So I think you might be screening if you're working with a cohort where the risk is more likely, such as if you're working with a DV service or if you're addressing specific sexual health behaviours or during the perinatal period, which is considered a high-risk time for domestic, family and sexual violence. But in most other circumstances, it's like those really excellent examples that you provided before where you just have your spidey sense out that if things don't quite seem right, you'd be asking and thinking about it. And I guess just in terms of what kind of case finding presentations we might think about, it might be where the person might be coming in more frequently if their symptomatology is unclear or doesn't fit what we might otherwise traditionally consider the natural history trajectory of the initial differential illness behaviours. And there are some specific presentations which we do associate as being more likely associated with domestic, family and sexual violence. So that's presentations with fatigue, chronic pain, chronic gastrointestinal or pelvic presentations, psychological presentations, including a suspicion of psychosomatic presentation, associated substance use, suicidality, and as I mentioned before, just being really on high alert during the perimenopause period and around issues around reproduction, including frequent STIs, postnatal depression, prematurity, or around the perinatal period as well, where you might want to think about it. So I thought I'd just put that up as a caveat before we kind of talked about making areas safe, because it is important, but we also probably just need to be on high alert in these specific circumstances as well. So I guess, you already mentioned posters, you mentioned, advertising. I'd also say there's something about the time that you spend with someone. So a lot of what you were talking about, in one of your case examples, it took 10 years before that person disclosed. And I would say that's actually quite common. And in fact, I think the evidence does show that, it can take equivalent to those periods of time before a person actually discloses. And that it's really important just that you are willing to hear what the person has to say, but that you're not rushing them. So I do find that in the storytelling of their story, and I think Dr. Ellie Friedman spoke about this, whilst it's really important for us to uncover strangulation, that bit of the story doesn't always come out quite readily because they have to often make sense of everything else that's happened to them within the context of that. And sometimes if you're forcing them and it brings back the memories and it's hard for them to disclose, it's actually not necessarily a safe place of disclosure either. So we just need to be really mindful of that. It's listening out for hints that there's something that they want to talk about, and respecting that they might still be working out how to talk about it, just like the last example that you gave. Sometimes what I might do if I feel like someone has something to say is I indicate and flag that I'm willing to listen when they're ready to, but I also might just provide resources for them. So it'd be where I would say there's 1-800 Respect, there's Inside Exchange, which is great in terms of giving patients stories in their own language about what the experience might be. So it means they could potentially explore it on their own, and then it just keeps the door open to them returning to discuss it further. And I think we just need to be mindful that, look, GPs are already seeing patients who've experienced this within their clinical practice. It may be that they're not necessarily recognising it's occurring, or they're not always quite sure how to respond. So I do think it's probably just worthwhile just thinking about how you might account for this within your workflow and practice culture when you consider making this a safe place of disclosure. You know, these consults often do take more time initially. I would say my thing of time, you know, I'm describing a thing where you might over multiple consults be signposting it, but at the time when they're really ready to disclose, that might take time once they start sharing their story. So if you appropriately allow time and space to let the patient's story unfold, and at the time when they want to disclose, it actually significantly improves the ability of the patient and clinician to work together more effectively to address the real issues underlying. And if we go back to what might be some common presentations, you know, it actually can reduce some of the distress on the part of both the patient and the clinician to properly be addressing what is actually underlying those presentations as well. But otherwise, if we're unaware of the risk of domestic family sexual violence or sequelae such as neurocognitive or functional disability, we won't include it in the management plan, and that's a really poor outcome for all parties involved. We also see patients longitudinally over the lifespan, and sometimes in the context of multiple family members. So it might provide more opportunity to develop a relationship plus the family context. And it might be that there might be a patient seeing multiple clinicians within the practice as well. So you might want to think within your practice what might be the process of information sharing if there's a concern, to ensure that you've got important concerns such as domestic family and sexual violence continue to be followed up as appropriate. But you also need to remember that they might have other health needs that need to be addressed alongside this. So they're not going to want every single consult with you to be about this. They want their pragmatic needs actually met. So again, it's balancing the pragmatic with the empathic. You know, it's really important to feel like you're not working alone in this. Like, it's possible to have structures and supports fully within your practice, or you might need to reach out externally, have a process where you can draw on expertise. And if you know that the consult's going to take a certain amount of time, then just plan for it. So sometimes, you know, we all have had experiences where there's an urgent situation that arises which was unplanned for. But if you can see it happening and you do get a sense when it's happening, start to enlist assistance at that point. Like, you might, I'm just going to pause there. I can see that you are going to need some time to address what's going on. I'm just going to make a phone call just to make sure we have that time. So it might be where you call your administration and or potentially colleagues, so you can kind of try to reschedule and reorganize what the rest of your appointment book likes, or that a colleague might step in and assist with the other waiting patients. And practice managers and admin might need to be aware of policies and processes around that, as well as around safety of information disclosure, particularly in domestic family and sexual violence when, again, you are seeing multiple family members as well. Where possible, I schedule the patient in before lunch or at the end of the day, and for the time I anticipate it needs. So, you know, I know some people say, oh, you only have, you know, a certain amount of time, but I just find that life doesn't work that way. You just have to plan for what actually happens in life, and it makes it much less stressful if you do that. So if I plan for what I anticipate the time to take, I don't feel quite so time pressured by patients waiting. And I've also set up my billing structure to reflect this. So MBS item level E's help. And if the patient does have some capacity for gap payments, because some patients still do, then I recommend they're registered for the Medicare safety net and pharmaceutical safety net, because that helps reduce the financial burden of that as well. And if they're eligible for veteran services, they might have the capacity for additional veteran services. You utilise chronic care plans and health assessments and case conference numbers to optimise multidisciplinary care options. I try to have completed what we need to do within the consult itself rather than leaving it to outside clinical hours. And it's not just because of Medicare, it also means that the patient's informed and aware, and they can provide feedback at the time. And also, I don't feel like I've got an extensive additional task list at the end of the day as well. For documentation, you might want to think about having some templates or autofills where possible. And I know that's not always going to be possible, but there are some standard things which will potentially be able to be streamlined. And it is really important that you need to ensure there's accurate note-taking and inclusion in individualised care, even within your template as well. So you would have to think about how you structure that up, but thinking about that in advance may help the streamlining of your day as well. So there might be some common pathways that you can share processes within the practice. Some GPs utilise their practice nurse, or they might be lucky enough to have a social worker or a psychologist to work together with them. Look, I work part-time, and so it's really important in my context to be sharing care. So we do have delineations of roles, but it can be helpful to have care shared between two providers to mean that the patient's got someone they can trust reliably, even when you're not there. And it also reduces the burden on one person if they're not there all the time, to feel like they're not leaving unattended issues when they're not present. But it also helps the clinicians to be working together and to build skills within the practice, rather than have clinicians feel like they're holding the burden of care alone as well. You might want to consider whole of practice training for domestic, family and sexual violence, which might be available through some primary care some PHNs, primary health networks, or through the Safer Family Centre. I think I saw Courtney put in some links in the chat as well. But in December, in the Australian Journal of General Practice, we actually had a focus edition on abuse and violence in families, and there is an article by Joanna Lynch and et al. On integrating understanding of and care for trauma into general practice. So it looks at whole of person care and trauma-informed care, and might be really useful for you to have a look at as well. I'll put that some of these links in the chat, as well as there are a couple of resources on identification and response as well.
Thank you, Dr. May Su. I think all of that information leads perfectly into our next slide on making a multidisciplinary response. So, as demonstrated in both case studies shared during this webinar, strangulation impacts a woman's physical, emotional, mental, and psychosocial health. Other case studies collected during this project showed the health implications of strangulation, included related brain injuries, impact the woman's quality of life by limiting their ability to participate in work, complete their studies, make decisions, socialize, leave violent relationships, form healthy relationships, and their overall happiness. As the main coordinating point for women's health issues, GPs play a pivotal role in supporting multidisciplinary responses to women with experiences of strangulation. Making a multidisciplinary response will include identifying the woman's needs. So, for example, if a patient discloses historical strangulation, you know there's a mechanism of injury for a brain injury, and assess for a new and evolving neurological symptoms, and manage and provide referrals based upon those assessment results. Considering safety, so including by making sure that you don't let the woman go home with the perpetrator with a referral that isn't safe for her to carry. So could it be sent directly in an email? to the service, or making sure that she doesn't go home with medical advice that isn't achievable in a violent and stressful domestic setting. It also means considering the client's long-term needs and connecting with services that can support her throughout her healing journey. It is keeping children in view. So this isn't just in terms of fulfilling mandatory reporting obligations, but also considering the intergenerational effects of violence, connecting kids present in the home for strangulation to early intervention services. We also need to remain cognizant that kids might be experiencing violence themselves, including strangulation directly from the perpetrator. And finally, keeping legal and compensatory options in mind in case the woman chooses to pursue them down the track, like paying attention to how we record incidences of strangulation in our clinical notes. So returning to Opal's story, you may ask, how did Opal receive a multidisciplinary response, given that she lived in a rural area that had no brain injury services or appropriate allied health services available to help her? So Opal's town is home to Women's Health Northern Rivers. When Emma Siegel, the manager of this women's health centre, identified there was a gap in their referral pathway, she went on to apply for a separate grant to help fund brain injury and allied health services for local women who had experienced strangulation. She got those monies and the Pathways program was born. With this funding, Emma was able to get Opal and other clients the centre sees the help they needed, delivered in a place they already felt safe and comfortable. This is a great example of why it's important to stay connected to community services in your area. Non-government organisations often run time-sensitive initiatives that may be helpful to your patients. They also need to know which GPs they can safely send women that contact their service to. So it's a win-win by reaching out and making those connections to ask what programs the centre has that might benefit your patients. So Dr. May Su, how would you make collaboration work effectively when referring patients to external services?
Yeah, look, it can be a really big deal for a patient to see another person to have to tell their story again. So with the patient's permission, I usually include a formulation of the events that have contributed to the presentation. And there are lots of different ways you can do this, but the most commonly used way in health is what we call a biopsychosocial formulation. You know, what are the biological, psychological, and social factors which have predisposed, precipitated, and then perpetuated this presentation, and what has been the initiating or triggering event as to why they're presenting now. So this can help create a shared mapping that you work collaboratively with the patient to develop. And it just helps them provide a bit of a succinct story that they can use when they, and they don't even then have to retell it. It might actually be just part of the actual referral documentation that you use in multidisciplinary referral. And I'm going to pivot back to the care framework that we talked about, which is choice and control, action and advocacy, recognition and understanding, emotional connection. So again, this brings... doing a formulation, it allows the patient choice and collaboration to decide what are the issues we're working on and what are we prioritizing on, because you may have to choose to focus on one at a time, and what exactly is going to be addressed in the process of referral, because I think that can be really confusing for the patient to recognize that sometimes referral services don't address or fix everything. They might be looking at just one aspect of what is going on for them as well. So, you know, as the recovery journey continues, you know, they can work through their options for how they address all the various issues, and they can call out for assistance where they might need action or advocacy. And, you know, clinicians can help provide some advice and support to guide the choices. And sometimes we may have to sift through the appropriate health responses that might actually be available. However, there's not one clear path on a recovery journey, and I always feel I'm continuing to learn from the recovery journeys of many of my patients who choose to share what works for them and what might not always be what we thought they might choose. It also reduces some of the burden on the clinician, the fact that the patients have the choice You are informing them and empowering them by keeping them informed of what their choices may be, but you are ultimately not responsible for their choice as well. The patient should also be aware of the referral that you are referring them, the purpose of the referral, what information you're conveying, and sometimes that actually takes a bit of time working with the patient about that process, including what they might need to prepare, what the process once they're referred might look like. We might discuss what might make that experience easier. For example, they might plan to take a support person with them, particularly, we talked about some of those functional impairments that a person might have. Or they might take some prepared questions or a summary of their symptoms or a process of note-taking. In some circumstances, I might even facilitate that first meeting by direct introduction, or occasionally it's been a joint first meeting. If there might be a wait time before the appointment, you might want to consider what the patient could be effectively doing to prepare for this appointment. And I'm going to include a resource in the chat as well. This was actually an article that Professor Kate Wilhelm and I wrote in 2024, which looks at some pragmatic strategies about what a person might be doing in preparation for a referral pathways. It's in the context of a mental health referral, but I do think that the same guiding principles still apply as well. And in collaboration with the external services, we need to ensure that there's an effective communication process. So, usually collaboration means the services are coordinated together rather than that's transition from one service to the next. So you don't graduate from your GP and get referred out and never see your GP again. You're working together as a team. These are often very complicated issues, and you're continuing to work together. So you continue to need to actually communicate with each other. And there might be some competing demands from each service, particularly because one person might have lots of different recommendations of what they request for that one specific issue that they're managing in that person's care. And you as the general practitioner need to actually be pragmatic and prioritise what is feasible for this individual with all of their other competing demands, bearing in mind they might have other family concerns which are occurring at the same time. So in more complex care arrangements, you might need to have a process of how you coordinate that care or case manager, and the more complex the processes need for collaboration, the more important you need to have a process of communication process. So I may also request that in particularly complex situations that we have a coordinated management approach so that we're not overwhelming the person, particularly if you are thinking about them having acquired brain injury as well. If there are police and medical legal issues, you need to also make sure you're supported by your medical legal team who can advise you if you're being requested to provide information, including medical legal documentation, and they can even talk you through how to write that. So, that could be a really important resource to lean into. And the processes need to be really clear about any handover of information. I always inform the patient if I'm sharing information to an external organisation, bearing in mind there might be some really significant confidentiality concerns.
Thank you, Dr. May Su. I really liked how you unpacked the process of what we would call at a women's health centre a warm referral. I really liked that.
Warm means so much.
I know. So remember, you're not managing these issues alone. Beyond the other clinicians within your practice and specialist services in your local area, you have clinical guidelines. The resources on your screen and your local PHN health pathway support healthcare providers when it comes to medical examination and management of strangulation. Your health pathways also include local referral pathways and services you can refer to. So going back to the 3 key insights for improving outcomes for women with these experiences, the final one is delivering appropriate health promotion. On the screen is a quote from a victim survivor who was interviewed as part of the Queensland Law Reform Commission on non-fatal strangulation. The commission found the majority of victim survivors interviewed did not receive any medical information from medical professionals, police, or others about strangulation, its consequences, causes, signs and symptoms, and how to look after themselves following strangulation. The victim survivor received a general information about being hit on the head, but nothing related to her experience of strangulation. In addition to the lack of accessible, affordable, and acceptable brain injury services for women, there is a lack of information available for women that addresses both the brain injury and the violent domestic context in which it occurred. We found we needed to do some work to fill this gap. So you and other healthcare providers have the resources needed to deliver effective health promotion relating to brain injury caused by violence. We worked with a group of multicultural women, the Women's Health Centres, and received feedback from academics and professionals in brain injury and domestic, family and sexual violence to create a pair of resources that can be used by GPs and other service providers. The resources are Recovering from Brain Injury booklet for women and the accompanying practitioner guide. The guide includes conversation starters that can help you create opportunities to hand the woman the booklet and ways to discuss and tailor brain injury health advice to what will work best in her individual situation, particularly if she's still living with the perpetrator of violent abuse. We told our teams, even when there is a service gap, so no affordable brain injury services for women, it's important that women are given information about brain injuries to potentially understand and make decisions about their own health. Understanding you may have a brain injury might finally mean you understand what's happening in your body. You stop feeling crazy and you forgive yourself for not having the executive function you need to plan to leave a violent relationship without help. You can get print-ready versions of these on our website. Health promotion messages related to strangulation in the context of violence focus on approaches that support safety planning alongside ways to reduce health risks. Using the same health promotion approaches with patients who engage in sexual choking is likely to isolate patients, exacerbate feelings of shame, and prevent them from disclosing or seeking help in the future. We made a resource that sets out 8 evidence-based ways you could approach delivering health promotion to different audiences of people who currently or may be considering engaging in sexual choking. Some of the approaches listed in the booklet include reinforcing that sexual choking is never risk-free and building the person's capacity to identify and redirect to alternative sexual activities. The booklet, which includes practitioner examples, is available on our website. You'll also find teaching tools like the graphic on the screen, which can be used to encourage help-seeking behaviour by helping clients understand that visible signs of sexual choking mean a more serious event has occurred. We also worked with a men's behaviour change practitioner on a video to model how you might talk to men who use violence about sexual choking. Dr. May Su, given that range of health impacts of strangulation, what is the specific role that GPs play when responding to women with these experiences?
Look, I recognise that what I speak to in the context of the general practitioner role also acknowledges the role of any first responder or clinician working with someone who's experienced strangulation. So it's really important to recognise there are very many different social, cultural and subcultural views on the role of strangulation, particularly within sexual practice. And in the context of abuse and violence, there's also the additional elements of control and incredibly significant risk of physical harm, including risk of homicide, intentional or otherwise. So GPs may be the first person disclosed to, but they're actually the most effective when they're working in a team, particularly when there are complex situations that include domestic, family and sexual violence and potential serious physical and psychological harm, sometimes to multiple family members. We encourage general practitioners to work together with existing supports, and this might include DV, legal, women's health services, court advocacy service, other specialist and allied health supports. Our role as general practitioner is to provide therapeutic relationship and pragmatic response throughout their recovery journey with the support of existing resources. You should always feel supported in this role. some practitioners who are already experienced with DV may feel it's sufficient accessing the resources we've mentioned throughout this webinar and working within supported multidisciplinary teams, and that's fantastic. I would say though that most practitioners also find it helpful to have a process of peer support. This might exist already within your practice. Some PHNs now have additional funding to support general practitioners working with domestic violence. 1-800-RESPECT is available nationally 24 hours for both advice and support. GPs and fellows are welcome to join the RACGP Specific Interest Group Abuse and Violence in Families, so just call out if you want to. And it's also really important to recognise that essentially it's the patient's journey that we are supporting. This dictates how they progress and the pace that they do so. We can assess, provide choices and options for how to respond to health concerns, and recognise the person's agency in the response. In the situation where there's cognitive or psychological impairment impacting on decision making, we can support the process of decision making. The goal is to support increased empowerment if and as capacity increases. And when there's a lot going on, recognise this, slow things down in order not to overwhelm the patient or ourselves.
Thank you, Dr. Wei-May Su. So our work with GPs saw us create resources, some of which are up on the screen now. The latest resources included an article we co-wrote with GPs in the British Medical Journal on the harmful effects of sexual choking and the role GPs play in delivering health promotion here. And 5 podcasts published covering sexual violence, domestic and family violence, and brain injury. These resources may be helpful training tools for other GPs and healthcare providers working in your clinic. You'll find them all on the dedicated page for healthcare providers on our website at leftnomarks.com.au. So while this particular Women's Health New South Wales project concluded on the 31st of July 2025, we're still working with Women's Health New South Wales on workforce capacity building initiatives and are very happy to chat about strangulation. By working together, we hope to ensure that there's no wrong door for women experiencing strangulation, sexual choking, and brain injury, and that women's holistic needs are being met when they choose to disclose these experiences to us anywhere in Australia. And then, Dr. Wei-May Su, I'd love you to finish off here, and I'd love you to share what you'd like, what your biggest wish for what GPs would do to be better supporting women experiencing strangulation.
Look, I really just want to emphasise the importance of webinars like this in terms of increasing awareness, because if we are not aware that this is something for us to be mindful of, we don't look for it. And I think it's a really important thing for us to remember that none of us is alone. We should all be working together to help support the person who's experienced violence and her family.